there are a bunch of practitioner related issues that create barriers to care as well. In 2007, the VA surveyed all of its practitioners who take care of patients with hepatitis C. And we looked at, there are about 160 big facilities within the VA system and many other smaller, what we call community-based outpatient clinics. Most of the care is delivered in these big facilities. And we got most of those big facilities to respond to this survey. And the survey was really not only about clinical care, but I'm just going to present one question which I found interesting. And as you can see, many people in primary care, GI service, hepatology, mostly physicians, a lot of nurses who responded to this survey. And I found this kind of fascinating that the question was, how long are patients required to be abstinent from alcohol prior to being evaluated by a specialist for hepatitis C? And while it's heartening to think that abstinence was not required in 67% of those respondents, but a third mandated some level of abstinence before being evaluated. And I think, to me, that's a fairly significant problem that's based on our own discomfort, probably, with seeing people or feeling like they're not going to be eligible for antiviral treatment, so they need to go somewhere else or get sober before you come in. And I think it's a big problem because I think we fail, or my belief is that I think the primary care docs and the hepatologists have a role to play in educating and helping people to become abstinent. That may be debated, but I think it tells you that not even evaluating patients, there are many people who are excluded from care, who get the care, but there are a lot of people who never actually get to specialty care to be offered or at least engaged in a process around antiviral treatment. Again, this is another recently published review of a survey of clinicians taking care of practicing in low-income, medically underserved communities, mostly about their care of hepatitis C patients. It was a web-based and paper survey. And again, 74% of those clinicians, these were primary care clinicians, did not refer active alcohol or drug users or people with depression for specialty care. Again, I think that's a huge problem. And I think, as we've heard a little bit about today already, the education and engagement process takes time. And so I think the sooner we can get people into care and engaging in a process of care, hopefully you can start to address some of the substance use and also psychiatric problems that may help people actually get onto antiviral treatment. So there are a variety of patient-level factors related to psychiatric and substance use disorders that are barriers to care. There are clearly practitioner barriers that create reasons for not engaging in care. And I didn't really talk about the systemic things, but and I don't know of any clear studies that have looked at systemic barriers, but it's interesting to note that in the VA system, we actually practice in a fairly integrated way. So there are, within the same building, there are psychiatrists, social workers, psychologists, hepatologists, but we don't talk to each other very well, and we don't interact in a way that is, we get into our silos and we practice in our silos. We don't practice together. And I think those are some of the, even in a highly integrated system where we just have to go a couple of floors up, we basically don't talk about mutual patients. And I'm on the first floor of a very large building, and the hepatologist is on the third floor. And I started doing this about 12 years ago, consulting to the hepatology section. And it was mostly because there was one interested hepatologist who wanted help treating more patients. And so he engaged the services, the psychiatry department. But I think even in our highly integrated system, we don't have great ways to communicate that fosters engaging these patients. That's true for the substance use disorder section in our hospital too. They don't have a great sense of referring people up to the hepatologist as well. So I think those are, it's even worse in probably non-VA settings where in order to get a psychiatrist or a psychologist or a social worker involved with general clinical care, you have to talk to 5 different insurance companies. That's a problem within the U.S. system. But, I mean, these are just some of the systemic barriers that I think are pretty well known and pretty clear. But there are a variety of patient, practitioner, and systemic barriers that impede access to not only just general engagement in care, but also antiviral treatment. So there's a lot of data about adherence, the impact of psychiatric and substance use disorders on adherence to care. And I wanted to just pick out one study. This actually happens to be a VA study, a retrospective review of about 650 hepatitis C positive patients, 294 with a psychiatric and substance use disorder, and 353 controls. And sort of a nice summary of this is that, as you can see, not very many people were treated in general, about 28% of the cohort in each of these groups, with substance use disorders being treated much less frequently. But once they got on treatment, those with psychiatric disorders, this middle group, MI alone, had completion rates similar to those who did not have psychiatric and substance use disorders. Completers and the sustained virologic response or response to antiviral treatment were similar across these groups as well. So this group didn't find huge differences in once people got onto treatment, that the outcomes were that much different. And I think there are a number of other studies that suggest similar results, that adherence is fairly good once you get people onto treatment. And many patients can tolerate it in many different ways. This was actually a big study based on a multi-site VA study of about 25 different VAs. And it looked at about 4,000 veterans. And this was a subset of these patients who were looking at the impact of alcohol on antiviral treatment. And this was with the old interferon and ribavirin, so not pegylated products. But the impact, we looked at the impact of recent 12-month alcohol use versus more recent or no use. And as you can see, the comparison between drinkers and non-drinkers, the sustained virologic response rate was very similar, the first red circle there. And really looking at more recent use, while the SVR rates or the treatment response rates were different between those people who were not using alcohol within the last 12 months versus those who were, there is a statistically significant difference there. It was essentially washed out once you took into account that people who were recent drinkers tended to drop out of treatment or discontinue early. So recent alcohol does appear to have some impact on adherence to treatment. Again, we can argue about, I think my perspective would be that we probably needed to do a better job of helping these folks deal with their alcohol use prior to treatment.